So it's my pleasure to introduce Dr. Burton Lee today. The burden of critical illness is disproportionately high in regions that lack trained clinicians or facilities that can care for such individuals. And Dr. Lee is going to present his experience in providing context-appropriate approach to critical care in resource-limited settings, including training of national physicians and clinical officers. Dr. Lee is the head of medical education and global critical care in the critical care medicine department at the National Institutes of Health in the US. He has made numerous contributions to the education and training of medical students, residents and fellows, both in the US and sub-Saharan Africa. And I'm sure he'll tell us a lot more about his background as well. So Burton, it's just a pleasure to have you today. Thank you so much for giving your time, and we really look forward to hearing what you have to say. Thank you.
Well, good morning from at least from the East Coast of the United States, everyone, and thank you, Dr. Saunders and ICMDA for this kind invitation. I have the pleasure this morning to speak to you about critical care in low and middle income countries. And then particularly, I'm going to be talking about how to support these efforts through medical education. As Dr. Saunders said, I'm the head of medical education and head of global critical care. And I would consider this really an honor for me to be able to talk about these two topics that are really near and dear to my heart. And those are the topics in medical education and global critical care. So I want to tell you a little bit about my own journey in this area. In 2010, I had the opportunity for a one-year sabbatical, and after some research and a lot of soul searching, I was able to find a place to work in Kenya as an intensivist. So in 2010, I packed up my bags, took my family, and moved to Kajabi, Kenya. It's a pretty large mission hospital that is now run by the Africa Imam Church. I'm sure some of you are very familiar with that hospital, and it's a hospital that is certainly in need of a lot of different subspecialty supports. But it's a fairly sophisticated hospital, at least by local standards. There are a lot of surgeries and technology that is available there that is not available in most parts of sub-Saharan Africa. And that's important for critical care since, as you know, it's a fairly resource-intensive field. So you need a bit of infrastructure to make that happen. But it also turns out that that 1 year, I was able to accomplish very little. And for those of you who have experience in cross-cultural settings, I think this will resonate with you. But it turns out that the world does not necessarily move according to your time clock in your mind if you're coming from the West. And actually, a lot of it happens at a different pace. It happens through over cups of chai. It happens over lots of casual conversations, and most of it is through relationship building. So bottom line is, I thought I could accomplish a lot in that 1 year, because 1 year is a long time, at least in some ways. But that actually quickly turned into 6 years, and we stayed until both of our kids actually graduated from high school in Kenya, and then the younger of the two was ready to start university back in the U.S. So for those of you who are not familiar with Kajabi, let me give you at least a brief intro. So here is the map of Kenya itself. Here on the upper left corner, the Indian Ocean is out here. Nairobi, the capital, is here, and then Kajabi is a small rural village, approximately an hour and a half northwest of Nairobi, as you can see. And then here's a satellite view of the area. The hospital is down here, and the view of the hospital from one of the rows looks like this. We actually lived in different parts, but for the latter part of our time we actually live in this house, which is a short walk from the hospital. And then our kids actually went to school at Rift Valley Academy, which is just above the hill there. And my wife actually taught English for several years there as well. So the kind of work that we did there was the whole gamut, really. One was obviously clinical care, taking care of patients in the ICU. But much of my mental capacity was actually spent not just in patient care, but in other areas such as resource capacity building, as to support critical care efforts. A whole team of us, including myself, had to be concerned with equipment and fundraising and supporting some of the resources that are needed to provide critical care. We also got involved in research capacity building, as we'll talk more about, because I think there are a whole team of very, very bright and talented African physicians and other clinicians who are actually quite interested in doing research to help build a database that is more relevant to sub-Saharan Africa. But the truth is, I think most of them are overstretched already with their clinical burdens. And so they didn't necessarily have the opportunity to pick up the research skills. So I did a lot of teaching in that area. And part of it was actually I got involved with Cabarrus University, which has a master's level program for physicians. And I was involved in teaching, as an example, a biostats and research design course there. And then the main area that I want to talk to you about today is the clinician capacity building. Kajabi Hospital is involved in training all kinds of different clinicians from all different subspecialty and specialty backgrounds. But one of the real blessings of having been there is actually we were able to start an emergency critical care clinical officer, or an ECHO, training program by the time I left, and it's something that, again, I'll tell you more about. So the area that I want to focus here, like I said, is in the side of medical education, which is clinician capacity building. And so I think graphs like this is no surprise to many of you, and you're quite familiar with it. But let me take you through some of the things that went through my own mind as I went to Africa and as I thought about clinician capacity building. So here's a review article in the New England Journal of Medicine from some years ago. It's charting here a theme that I think will resonate with most people here in the audience. On the x-axis is the supply of clinicians. So these are doctors, nurses, and midwives per 1,000 people. And as you can see, Europe and the Americas lead the clinician supply, being far to the right. On the y-axis are the daily adjusted life years in terms of burden of illness per 1,000 people. And as you can see, sub-Saharan Africa and then Southeast Asia lead that on the y-axis. And then the relative size of these blue bubbles represent the percent of the supply of clinicians around the world. And as you can see, Europe, Americas, and then the Western Pacific is actually quite big, with a fair number of clinicians. But you can see sub-Saharan Africa stands out as a very tiny bubble among all the supply of doctors, nurses, and midwives in the world. Again, just getting into a little more numbers here. So this is the data of just the physicians per 100,000 people in the US. It's 549, and sub-Saharan Africa, as you can see, is less than 1% of the supply that is available in the US. And this is the same theme, but a different visual representation. This is the world map as put together by the University of Sheffield group. And it is depicting, again, the supply of clinicians. And it's the supply per population. So as you can see, much of the Northern Hemisphere, including North America, Europe, and Asia, are quite bloated. And then you look at the South, and much of the South looks quite emaciated. And of course, one of the most emaciated parts of the world is in sub-Saharan Africa. And this, of course, is where Kajabi Hospital is located. And so, so for me, it made sense to devote my time and attention there. Now, before we get too much further into the critical care aspects, I know in some people's minds, and I think it's a legitimate question, which is, what is the role of critical care since it is so resource intensive, and shouldn't we be prioritizing primary care, or even better yet, public health? And I think that's a very valid point, and I can't necessarily argue with that comment. However, here's a statement from the World Bank in 2006, which in their analysis that when they looked at low and middle income countries, the lack of emergency and critical care has a substantial impact on health outcomes, and actually a more robust infrastructure for emergency medicine and critical care medicine has the potential to impact about 45% of the deaths and 36% of the disabilities. So I think in my mind, this is not a matter of only public health or only primary care, and certainly only critical care, but it's really a matter of prioritizing things in a balanced form so that all of them get the appropriate need and support. So so I think I already mentioned the fact that in 2016 I moved back from Kenya back to United States when the younger of our two kids were starting university in the U.S. And I was fortunate enough to have a job at University of Pittsburgh as a faculty member at the medical school there. And so one of the things that really struck me when I got back is this stark comparison. So as you know, Kenya is a sub-Saharan African country that has approximately 50 million people, as opposed to the US, which has about 330 million people. And this is the number of ICU beds in the US, which is about 95,000 ICU beds. I think this number has been rapidly fluctuating due to the pandemic, but this is pre-pandemic numbers. In contrast, in a country of 50 million people, there are only 150 ICU beds in Kenya. I was told at one point that when I was there in 2010 that I may be the only pulmonary critical care physician in Kenya, but I know by the time I left, I was told that there were about 12 critically care trained physicians in Kenya. And in contrast, this is University of Pittsburgh. This is one hospital at our university. One hospital has 150 ICU beds, which is obviously the same number as the entire country of Kenya. And within this one hospital, there are 186 critical care physician faculty at the medical school. So, and so I think the huge disparities are well known and obvious, and this has been actually a source of contention, I think, in my mind and in many people's mind as we face the pandemic. So in terms of capacity building, I want to mention that there's been some prior efforts in the area of critical care. So here is a group, it's called the East African Training Initiative. It started a few years before us in 2013. It's centered in Addis Ababa, Ethiopia. And this group has partnered with some institutions in the U.S. At academic centers, and they are trying to train several physicians who are pulmonary and critical care specialty trained. But our focus was deliberately a little different, and it's in part because in our database in Kenya, for example, we found that a group of clinicians that we call clinical officers were much more abundant than physicians. So in part, we didn't want to take away valuable physicians from surgery, obstetrics, and other fields to take them into critical care. At the same time, there were a number of highly talented and motivated clinical officers who are similar to physician assistants in the U.S. in that they're not nurses, they're not physicians, but they're trained clinicians who can function much like a physician assistant or perhaps nurse practitioners do in the U.S. And since there's a relative abundance of those people, we thought they would be a better target. And also, at least in Kenya, a lot of the clinical officers probably would have been and could have been physicians had they had more financial support through their, through their years of education, and they're equally bright and as motivated as a physician work staff. So we targeted that as our workforce. And then what we ended up developing is it's a group, as I mentioned, called the Emergency Critical Care Clinical Officer Program. And it took approximately 5 years of my time there to get this started. And it's an 18-month training program where they learn all about mechanical ventilation, sepsis, and emergency medical care and trauma. And they learn to intubate and to perform other vital procedures. And this is the picture of our first graduating class. And so let me tell you a little bit more about Kajabi Hospital. In case you're not familiar with it, it's owned and operated by the African Inland Church. The entire leadership at this point, including the CEO and the board, is Kenyan. There are approximately 30 full-time physicians. Half are Kenyan and rest are expats. And in addition to the long-term expat staff and the national Kenyan staff, there's a constant stream of visiting clinicians and trainees from many places, like the US, UK, Hong Kong, Australia, and so forth. And the important thing here is that all expats, both long-term and short-term, serve at the invitation of Kenyan leadership. And there are numerous training programs now at Kajabi Hospital. They've long had medical officer trainings, which is a rotating PGY1 experience where they spend roughly 3 months in surgery, medicine, obstetrics, and pediatrics. But now there are numerous residency programs in family medicine, surgery, orthopedics, neurosurgery, pediatric surgery, nurse anesthesia programs, and most recently an anesthesia residency program. And then now the ECHO program for clinical officers. And this is kind of an interesting institution in that it has had a long partnership with high-income country institutions. So for example, the anesthesia program, initially with the nurse anesthesia program, and now with the anesthesia residency program, it's had long-term partnerships with places like Vanderbilt University, and so they have a long track record of successful partnerships. And this arrow is pointing to where the ICU is located on the second floor of this building, and inside it looks something like this. We had 5 ICU beds and 12 step-down beds for a total of 17 bed capacity for people who are in the critically ill population. We have things like CT scanners, which came in the middle of my tenure there, but we have access to portable ultrasound machines and also mechanical ventilators. And much of the educational efforts we try to standardize and put online here. So our learning management system was essentially Google Drive. And I think if you're familiar with that, it's just a free cloud account that we can all have access to. And it sort of breaks down institutional barriers, and it allows us to store all kinds of reading material and assignments here. So we got various chapters for our trainees here. Here's a chapter on sepsis, for example. And then we can house relevant reading assignments and questions for them to answer on there. And it's accessible on their phones and on laptops and through other devices. So as of 2020, we've had 4 classes that have graduated, and that means that we've had 24 ECHO officers who finished in 2020. Now that it's basically 2022, we've had more, obviously. And a small miracle of sorts is that we're able to navigate through the bureaucracies of government, and it actually quickly won approval through Ministry of Health, officially recognizing this program as an endorsed effort by the Kenyan government, and now it's a fully functioning program that students can actually come and take for full accreditation. So I want to mention some challenges and lessons that we learned through these years, and this is by no means comprehensive, but just some list of things that serve as examples. At least for those of us who are coming from North America, one thing that I quickly learned is that there are no respiratory therapists in Kenya. And the relevance to that is, the respiratory therapists in the US do a ton of work on behalf of the ICU team. So as a physician, oftentimes I never had to worry about certain things. But of course, without the help and the support of those very valuable clinicians, I had to learn it the hard way. So for example, here's an endotracheal tube that if you look closely, you can see it is completely caked with secretions. And the reason this is happening is because it is common to use a humidifier that is attached to the ventilator circuit that keeps the tubes from clogging like this. And it's such a standard thing that I never have ever had to worry about it in the US, because somebody else basically takes care of it for you. But in Kenya, we realized that these people that were intubating did not have humidifiers in. And so then, every other day I would run down the hill to try to rescue people, who were essentially suffocating from this. And so we had to learn the hard way that actually, that we need to expand our skills from what we're normally comfortable with or normally what we're aware of. And a solution to this is essentially a little device that we could put between the endotracheal tube and the ventilator that actually functions as a moisturizer, and it's called a heat moisturizer, and it basically prevents this from happening. It's not as good as a humidifier, but it functions almost as well, and we're able to prevent this from occurring. And so what that means is that we have to, do more training and education for our nursing staff as well as physician staff to make sure that they're aware of problems like this that wouldn't normally surface in the U.S. as prominently as this. Another lesson are the issues of cost and benefit, which I think is something that is going to be apparent to anyone who thinks about critical care. Here are some sample numbers from the World Bank about the annual per capita health expenditure in Japan, UK, US. As you can see, it ranges from about $4,000 to $9,000 per year per person. And the cost to take care of a mechanically ventilated patient at Kajabi ICU is approximately $90 US per day, which sounds like, that's pretty cheap, certainly by US standards. But in contrast to Japan, UK, and the US, in Kenya and Uganda, the per capita expenditure is only $45 to $44 or so. And so, this represents a huge amount of money, relatively speaking. And then the average person in around the Kajabi community might earn only about $5 or $6 per day. So each day in the ICU is a huge burden for the family, and so you have to be really realistic about about certain interventions and to make sure that it is really justifiable. along those lines, there's this phenomena that I became very familiar with, which is called the fixed budget effect. I think it's best illustrated using an example that's hypothetical. So let's assume there's a standard treatment for a serious illness, and it costs $10 per person to treat. Let's say it's a medication that a 10-day course costs $10. And it has a 50% cure rate, because none of these medicines are perfect, obviously. So out of 200 people, let's say that you treat with it, 100 might be cured with this intervention. And so this is where you are currently in terms of cost. The cost is $10 per person, and then benefit is that about half the people who get treated will be cured. In our context, we're constantly evaluating whether we should bring in new treatments. For example, should we bring in dialysis? Should we bring in norepinephrine as opposed to dopamine? Should we be using low molecular weight heparin instead of unfractionated heparin? And questions of that nature. So if you think about a new therapy that is more expensive, so let's say it costs $12 per person, but it has a somewhat higher cure rate of 110 people out of 200. And let's say a study gets published in the New England Journal of Medicine that says this is a highly significant finding. Then the question becomes, is this new treatment worth applying to this context? And this is the kind of thing that we were wrestling with all the time. So on the surface, you might think if you're right here with a certain cost, and you were here with a certain benefit, if you adopt this new treatment, which way do you want to move? Or which way will you move, rather? And which way do you want to move? Well, the only clear benefit in this, among the choices here, is to move to the right, which has more benefit, but at a neutral cost. So if it was option E, that would be a no-brainer, that you would want to do this. Option A is that you get more benefit and more cost, and that may be acceptable if you can afford it, but you wouldn't necessarily want to move in the leftward direction because you're losing benefit either at more cost. And so you can look at these various options and see which way this scenario would represent. Well, it's actually a little bit more complicated than it may seem on the surface. Because a lot of times we're operating on a limited budget and often through donations. So if you assume that you have a donation of, let's say, $2,400, and there are more patients who need the treatment than we have space or the money to treat. And so let's say there are 400 patients in this village who needs this particular treatment. Then let's see how far this situation with a fixed budget would help the community. So if you look at the standard treatment, people treated and cured would look something like this. Because it costs $2,400 at $10, you would be able to treat 240 people, as opposed to here, only 200 people would be treated because of the fixed budget. And then if you look at even the superior cure rates, the total cured would be half here, as opposed to about 55% here. And then what that comes out to is actually fewer people would be cured with a new treatment, even though it may be better in the New England Journal article. So a lot of things fall into this category, and I mentioned some examples already, but it takes a lot of thought and a lot of input from local people, local experts, to make sense of this kind of decision. So in this particular example, this would be if you were to accept this, you would move from this black dot to dot C, which means you actually get less benefit. Other things, the equipment is a major limitation, as I'm sure many of you are familiar with. One of the key interventions in the ICU among mechanically ventilated patients is to limit the tidal volume. It's the so-called lung protective strategy, which has been shown to reduce mortality in patients with severe respiratory failure. So here is a ventilator that we had initially that is telling us that the tidal volume is 408 mLs, which is a okay tidal volume. But the same machine is telling you that it's actually now expiring 1,579. So this obviously this discrepancy between inspired and expired, cannot exist in a equilibrium. And what this most often represents is some kind of a calibration error in the machine, which means basically the machine is no longer functional. So, so things like this is what we face every day, essentially, and so that's what led to a lot of the efforts to build our resources and to fundraise and to seek higher quality equipment that would deliver higher quality care on a more consistent basis without the need for constant maintenance issues. In terms of other resource building, this may come not so naturally to most people's minds, but it's actually the internet. So, so I had my boss at the time, which is, and he was just very generous with his support. And so he actually funded and made it possible for me to get this dish, which allowed us to have internet. And then you might think, why is internet such a necessary part of our capacity building? Well, at least in terms of medical education, this is what allowed us to have classes. We're able to give tablets to all of our ECHO officers, and then for us to conduct classes and to listen to lectures. This is actually my living room, and this is our patio where actually classes are being held. And so a lot of the resource capacity building was sort of the infrastructure building to make education possible. The last topic I'm going to present here is the idea of research capacity building through medical education. So here's a paper looking at the percent of biomedical publications that come from different parts of the world, with Africa, Asia, Europe, and so forth. And if you look, the highest percentage of the literature comes from North America, followed by Europe. So that's about 80% of the world literature comes from Europe or North America. And if you look at Africa, it's actually less than 1% of the publications come from this part of the world. Well, why is that a problem? Well, the problem is that a lot of the literature that is published in the West is not applicable or can be quite misleading if you don't consider the local context. So there are many examples of this, but one of the most classic one is this topic of sepsis management. So here's a paper by Dr. Rivers in the New England Journal of Medicine in 2001. And what all these things in red basically says is that this wasn't the most ideal paper in that it was not a registered trial. There was a small number of patients, only 263 people. And it was a single center study as opposed to a multi-center study. And there was some conflict of interest among authors in terms of their relationship to industry when they were doing this trial. Well, I think many of you are aware of this trial called the FEAST trial, which is 10 years later done not in adults, but in African children, and a much higher quality study in terms of the criteria that we mentioned. And what we found here is that actually the FEAST trial increased the mortality when you followed a similar protocol of aggressive resuscitation among African children. And then here is a study even later, repeated in US adults. Again, a much higher quality trial here compared to the first study. But this is 4 years after the FEAST trial, and they found actually no benefit of this particular intervention that was originally promoted back in 2001. So essentially taking a study from the New England Journal of Medicine that's done mainly in the West and then simply applying it to African context may not be the best thing to do. And even among these three trials, if you notice, there's still a discrepancy among all three in that one study, albeit this is a poorly designed study, showed benefit. This study showed harm, and this study showed no difference at all, neither harm nor benefit. And then if you look at another trial from Africa, here's a study by Andrews, which is applying a similar aggressive resuscitation strategy in Zambia. They're comparing, this aggressive therapy called early therapy versus usual care. And again, they found that this protocolized approach had resulted in more aggressive resuscitation with more fluids, more use of vasopressors, and they're able to demonstrate a faster lactate clearance. But again, just like the FEAST trial, it showed an increased mortality when you apply this strategy to sub-Saharan Africa. So at the very minimum, it suggests that you need to do studies in sub-Saharan Africa or in other low and middle income countries, rather than just simply applying what we find in the Western literature. So that is where we are right now, and then I'd like to just share with you in the last minute or so about our current efforts. I'm part of this group called the Global Critical Care Collaboration, and you see some of the people represented here. And so now, even though I'm back in the US, we're continuing to support medical education through our various institutions. We're still partnering with Kajabi Hospital, in part because of our long-term relationship with that institution. But we have partner hospitals in Kenya as well, which is one of their major academic medical centers. But we have other sites of in the US, like Beth Israel Deaconess in Boston, Mayo Clinic, the NIH, of course, University of Pittsburgh, which is where I used to be, and then Texas Children's Hospital. And all of us are partnering to support this Kajabi Hospital in all 4 of those areas of clinical care, resource capacity building, research capacity building, and then also a clinician capacity building. And what we're hoping to do is to provide a constant stream of ICU fellows and ICU attendings to rotate through Kajabi Hospital on a consistent basis. And we are hoping to provide support for all of those activities, like I mentioned. But as part of that effort, we're hoping to provide roughly a 1 year's worth of clinical coverage among the fellows and attending, so that we can free up African physicians and clinical officers to start training in their research capacity building. And then as part of that effort, we have actually one of our fellows in the PIT program will be heading back to Kajabi to become a full-time intensivist there. And then he will be also helping out with the efforts in terms of coordinating our collaboration. I think studies have documented that one of the major limitations to promoting research in places like sub-Saharan Africa is that there's no protected time and there's lack of trained researchers. So through this collaboration, we're hoping to, again, provide that kind of protected time for the Africans. I'll finish with this slide, which is that there are many papers that have looked at the ethics of short-term global health efforts. And here's a summary that is too small for you to read. So let me just summarize a few of the points as I close. They emphasize, for example, that there should be primacy of well-being of patients and the host institutions in these short-term collaborations. And the reason for that is because the benefit for the high income country volunteers is often obvious and it seems to be relatively high, but the actual benefit to low and middle income country hosts seems to be low. And it's often done at the expense of the low and middle income country host countries. So we want to be careful that we are doing this for the benefit of those people in Kenya in this example. And then they talk about having a minimal burden to host community and host institutions. And that's because often when a volunteer comes, you have to provide translators, you have to provide housing, you have to stop what you're doing to help that visitor and so forth. So we're working on housing to be provided. And then that everybody who comes through the G3 collaboration will be responsible for their own expenses. And then we want to be sensitive and respectful of the local culture. And as suggested by Dr. Whitehead and all, we will be functioning as an invited guest at Kajabi Hospital specifically guests that are invited by the Kenyan CEO and the board of the hospital. And then we want to be well prepared for our time. And so we will have a curriculum in place where people will be preparing both medically and culturally for their trip. And then we'll have a mentor at each high-income country institution, which is why we have the people from those 5 institutions listed there. And then we'll have a mentor at the low middle-income country institution, in this case, Kajabi, to help us to get acculturated and to function as well as possible in this context. So I think I will stop here and let me just finish by leaving you with my email address if you have any questions or comments, if you want to contact me about any of these things that I might have talked about that may be of interest to you. And thank you again for this great opportunity for me to share with you.
Thank you very much. Well, we've been listening to Burton Lee speaking on critical care and resource limited settings, and lots there to chew over. Lots was very new to me. And also now we've got a time of question and answer. So I wonder, Burton, if we could just start, can you just explain a little bit more about the training? You talked about the 2-year PCCM course in Addis Ababa in Ethiopia. And are your trainees trained there? And if so, is that distance learning, or is it whereas they work in Kajabi, or do they go there for a couple of years first? And what's the capacity of that course?
Yeah, so that may have been a little bit rushed perhaps, but so I mentioned the course in Addis Ababa as an example, another good example of trying to build up resource capacity in critical care. But they are a physician effort. So their trainees are all Ethiopian physicians, and it's a separate effort from what we're doing. What we have targeted intentionally, as I mentioned, are clinical officers, in part because they're more abundant, and we wouldn't be taking away resources from other physicians who want to be surgeons and so forth.
Okay, so the figures you gave of 24 ECHO people trained, 4 per year, those are purely within Kajabi, are they? That's
correct. Yeah. So it's actually not per year, but it's a total up to 2020 because we train anywhere from 4 to 6 people per year, and they are within Kajabi. And actually some hospitals around the country have even sponsored some of their trainees to come to Kajabi, and with the idea that they will go back to their to their sponsoring institution after their training.
And how long is the course then for them?
So it started out as an 18-month experience, and it's being slightly extended because I think the Ministry of Health has added some additional requirements for like quantitative reasoning and research and things of that nature.
And are there other centers in Kenya that are using a similar course with clinical officers, or is it just operating in Kajabi?
So it's principally at Kajabi, but many of the graduates have now left Kajabi and have gone to other institutions, and I think it is being well received. So there are other efforts that are being developed to duplicate the efforts or the success that's happened at Kajabi.
And are there other similar programs throughout sub-Saharan Africa that you're aware of where they're training clinical officers in critical care rather than physicians?
I'm not aware of that to my knowledge. That may indeed be the case, but I believe we were the first to train clinical officers in this way in sub-Saharan Africa, I believe. But I think the whole model of teaching or training non-physicians to function in these roles, is probably best represented by what happened at Kajabi about 20, 30 years earlier with nurse anesthesia programs. So it's certainly not without precedence.
Yes, and of course the American model is that you use nurse anesthetists, don't you, for a lot of routine anesthesia, which is not done in a lot of other countries where all anesthetists are trained medically. But I mean, you can certainly see how you've been able to increase the capacity of training. We've got a question here about research, and you mentioned that most of the research obviously is taking place in the global north. A lot of it is inappropriate for application in lower and middle income countries. Tim Chusick is asking here, surgeon working in East Africa, great presentation, Burton. Can you recommend quality journal resources coming from a global south perspective in critical care medicine or medicine in general, including bioethics? Well, that's broad, but should we start with critical care medicine? Who's publishing the best appropriate technology stuff?
Well, so I mean, in the field of critical care, I think the vast majority of high quality literature actually is still in New England Journal of Medicine, Lancet, JAMA. I think those three journals have data to back up that more than half, so at least the majority of the high quality publications are in those three journals. So whether it's global healthcare or not, and I think still the highest quality global healthcare articles are in those three resources, and then the other roughly half are scattered throughout all of the other ones, that have this endless list of things.
Okay.
And so now, now you can look at Lancet Global Health, for example, and they're also excellent resources, but the highest yield are still found in those three journals. So, like for example, the FEAST article that I mentioned, about the resuscitation study among kids that showed higher mortality with aggressive resuscitation is a New England Journal article, and that's a global health article, obviously.
Yeah,
and then
so
similarly,
it's New England Journal, JAMA, and Lancet. The big three. Yeah, great. Liette Bilon is asking here, when your trainees and graduates finish, do they stay in Kajabi or do they go to other areas or both? And what's the situation? I mean, how many places can they go where there will be adequate infrastructure and machines actually to use their skills?
Yeah, I think that's a great question. I know initially a lot of the initial graduates have stayed at Kajabi to gain more experience, but now they're starting to move to other areas. As far as the infrastructure that supports critical care, Kenya has made a national push to increase ICU capacity even before the COVID pandemic. And so there's been this, this effort. It doesn't necessarily mean that they are well equipped always, and it certainly doesn't mean they always have people who can run those, those equipment well either. But this is that's part of the reason why this kind of effort is so much needed, because it's not, you can't just say we're going to increase ICU capacity and then have it happen overnight. You need both a clinician capacity building and resource capacity building at the same time. And I think the honest answer is that they're not always aligned together at the same time in the same institution. But that's why I think efforts like this is so important. And by the way, I should also add that when I say critical care, it doesn't necessarily even mean ICU, because there's a lot of critical illness that happens in sub-Saharan Africa that's happening actually in the outpatient clinics that are just critically ill people. And then in the regular hospital wards, there are people who are critically ill from sepsis and respiratory failure. So this is somewhat independent of the location, like ICU location. This is more, how do you best care for critically ill people? Now, having said that, obviously it does require sometimes, more advanced equipment like mechanical ventilators and non-invasive ventilations and things like that. But it's not automatically mean ICU like it might in the US or Europe.
Well, you talked about 17 beds in the intensive care department, but of which only 5 were ICU and 12, I think, were step-down beds. Can you explain the difference between those two beds in terms of the care available?
Yeah, so I think the definition of those things will vary from institution to institution, even in the US. But the way it's structured at Kajabi with 5 ICU beds means that there's a separate room that is, that is walled off from the rest of the hospital, where there is pretty close nursing to patient ratio. So it's typically 1 nurse per 2 patients. And if you require mechanical ventilation or vasoactive medications, you would be in the ICU in general. And then these other 12 beds are, it's actually called high dependency unit over there, which is similar to step down units in the US. But the nurse to patient ratio would be a lot lower. Maybe 1 nurse might take care of 4 patients, for example, or 3 patients. And then you wouldn't be able to handle somebody who's intubated on the ventilator in the step down unit. But they may require very frequent monitoring, for example, because of their blood pressure or their mental status or their suctioning needs and things like that.
Okay. Doug Lindberg, who you may well know through CMDA, is asking, any thoughts on the scalability of this critical care training model using clinical officers and support network you built up to other institutions in other countries or other continents?
Yeah, I mean, I think that is the hope. So I think in the last couple of slides, I mentioned the GC3 effort, and that is one potential way to do that. But of course, Kajabi Hospital is a separate entity, even apart from GC3, and Kajabi Hospital is already doing that very well. So there are people from other parts of the country who want to come and train, and it's a self-sustaining program at this point, because we have our own graduates. These are the clinical officers who have graduated from the program, who are now the faculty. So there's still some physician input and physician oversight, but it's a fairly independent effort at this stage.
A question here from West Africa. Do you have any capacity to train people from countries in Africa outside Kenya, or are you really full out with Kenyan trainees?
That's a great question, and we'd love to train everywhere that where there's a need. I think at this current time, Kajabi has had, for example, people from West Africa who come in to train in pediatric surgery. So I think many of you are familiar with the surgical programs that are happening all across sub-Saharan Africa through PACS program.
Yeah, we had a talk from PACS about that last year.
Yeah. So there are examples of, let's say a surgeon from Liberia coming to Kajabi to train in pediatric surgery, for example.
Yeah.
So we could have similar kind of things, or alternatively is we could take this model and apply it to other countries.
Yeah. Dan Mort is asking, he says, thanks Burton so much for the talk. What would you consider to be the minimum local infrastructure necessary to realistically start thinking about establishing a critical care unit in a low resource setting? He goes on to say, I understand that Kenya in general is significantly more developed than many other sub-Saharan African countries. To what extent do you think the model you've established may work in less developed settings? So question about the minimum local infrastructure necessary.
Yeah, that's really an excellent question, and something that I sometimes get into in this talk, but I didn't have time to get into is I mean, like I often get asked by people from other parts of the, around the world, including Africa, to say, hey, we're interested in starting an ICU program. Can you help? And that kind of stuff. And my usual answer to that has been, great, but don't buy ventilators. Don't buy dialysis catheters and machines, but actually invest in nurses, because the bulk of real ICU care is done not by physicians, but by nurses. And so I think one absolutely necessary fundamental structure that has to be in place is a good nurse program. They have to be well trained. They have to be very attentive to the details, and to start even with the best and the brightest physicians and the fanciest shiny equipment, going to really be a failure, in my opinion, unless you have outstanding, dedicated nursing staff first. So that would be my biggest advice: is don't buy anything until you've established a very, very strong nurse infrastructure.
Yes, investing in people and training has come across so strongly today. Michael Shule, who's an anesthesiologist who's been training nurse anesthetists in Chad, so in Francophone West Africa, he's asking, is there any possibility of being able to share some of your excellent teaching resources, both for critical care and anesthesia, to train others from the programs in Kajabi? I mean, that's maybe something he could write to you about afterwards, but would you just like to comment on that? Are there any plans to make the material more widely available? You mentioned about having this on Google, on a Google website, so presumably, in the cloud and accessible. What's the place for that?
Yeah, absolutely. I think we really want to make this as widely available as possible. And so if you just write to me, I'd be happy to maybe talk to you further offline. There are people who are in charge of the ECHO program currently on the ground at Kajabi. So I could put you in touch with those folks as well. It's people like Pete Halstrap and John Matson and Hannah Gitura and so forth. So these are the current leaders of the ECHO program at Kajabi, and I'm sure they'd be more than happy to talk to you further about collaboration and also sharing resources.
Otto Christian Rowe is saying, we've heard you presenting the benefits of host LMICs of imported medical capacity from Western countries. He wants, wonder if you could comment on the effect of the brain drain. Are the people you're training disappearing to the West? I know PACS has been incredibly successful in keeping or encouraging their trainees to stay in sub-Saharan Africa where they're most needed. But are you losing trainees to the West, or are most people staying in Kenya?
That's a huge problem, as I'm sure many of you know. As far as the ECHO program, I would say number one, we're too new to have like extensive data to see what happens in the long run, which I guess would be the big question. But I think at this stage, the answer is no, in part because the ECHO program is recognized in Kenya, but it's not likely to be recognized in the US or the UK, for example. So I don't see that happening. Are they all staying at Kajabi? The answer is clearly no, but that's a good thing, right? Because you don't want to be all concentrated there. You want them to go to the more remote locations or to other hospitals. There's always been competition with Nairobi hospitals, and I think that is an issue, because Nairobi hospitals tend to be on the average, more private, richer, better resource, and also higher paying. So one of the problems that I think Kajabi has faced over the years is not only the ECHO officers, but all the trainees really get lured away to Nairobi and other big cities. So is that absolutely a horrible thing? I mean, not necessarily, because you need high quality care everywhere. I think on the positive side, I think these Nairobi hospitals are looking at Kajabi as a great source of training. So it's a form of flattery in some ways and recognition. So I think that's a good thing. But it is a realistic thing that people we train tend to get pulled away to other places. Some of which is not ideal for Kajabi itself, but perhaps great for the country as a whole.
Well, we say that imitation is the sincerest form of flattery. So if people are taking the Kajabi program and using it, that surely is a great thing and a real commendation to what you're doing. Burton, we've virtually run out of time, but I just wanted to ask you one last question about the cost of the care. You've shown how you can provide good quality critical care at a much lower cost than in the West, but you also mentioned about the cost to patients. And I just wondered, how do patients pay for critical care? And is that a limitation to some people having treatment? I mean, do some people just not get treated because they're unable to pay or because the resources aren't there?
Yeah, I think that's one of the more painful aspects of practicing in a place with resource limitations. I think in the U.S., arguably we spend too much money at the end of life and in critical care. But I think in places like Kajabi, it's the opposite, isn't it? If we had more resources, we could extend care. On the other hand, I think places like Kajabi, and I'm sure many places in sub-Saharan Africa, they actually do death better than many of us in the West. Because I think death is a much more conceived as a natural part of life, which it obviously is, and so it's not. I think when time comes and it's clear that things are not working, in general, I think people are more accepting of that in that culture than it is often in the U.S. anyway.
Well, thank you so much. We've got a number of other questions. Sadly, we haven't got time for those today. So it remains to me again to say thank you so much, Dr. Lee, for sharing your time, your expertise, answering the questions so well, making yourself available, and particularly for the example you've set. It's been said you can't meet the need, but you can show how the need can be met. And I think by establishing a best practice model at Kajabi, it will inspire many people and could be the start of something quite amazing. As you've said, just look at what PACS has achieved already, for example. So thank you so much for being with us. And thank you to all of you for joining us here today. We'll be back again. In the meantime, may God bless you. All the best. Thank you.